Okay, good. Now, welcome to another class discussion. And today we are going to discuss about the drugs used in the management of type 2 diabetes. And these drugs, we call them oral hypoglycemic drugs because their major function is to reduce the glucose in the blood, and that is hypoglycemia. So these basically they work on type 2 diabetes. As you know very well that type 1 diabetes depends on purely on insulin because the body is not producing any insulin in the body. So in this type 2 diabetes, you use these drugs if we have the patient is not responding to non-medical interventions like doing taking diets, doing exercises like taking a brisk walking for 2 hours or for 30 minutes or 2 kilometers per day, doing what weight loss and maintaining a BMI of 18 to 20 to 24, not taking fats. If this one does not respond, then you have to start your patient on these type of drugs in type 2 diabetes. So in newly diagnosed type 2 diabetes, in less than 5 years, these patients respond well to these drugs because their beta cells by the pancreas are being produced. So they are just required to be stimulated. But as time goes, this patient may require a combination of these drugs with the insulin because now the beta cells are diminished in production of insulin. So the progressive decline in B cells function necessitates the addition of this insulin and sometimes in type 2 diabetes. These drugs are not indicated in type 1 diabetes. So let us see the classification of these drugs. There is a class 1 drug which is called sulfonylureas. And this class of sulfonylureas is, we have the first generation of sulfonylureas, which is called, an example is glutamine, another one is chlorpropamide. The second generation is glibenclamide, which is very commonly used in our setup as drug and which can work for 24 hours. And the major problem with this drug is that it can induce hypoglycemia because it does not get metabolized very fast in the body. Another type of drug is glibenclamide and gliclazide, glipizidine, and glipebrimide. Another class of drugs is bigonines like metformin, and you know very well that metformin is the basis of treatment of diabetes. The other one is metformin, and you know that metformin is commonly used in our setup. The other class of drugs is meglitinin analogs, which examples is like lepagrinendin and natagrinendin. Then we have the other drugs, we call them TZD or thiazolidinones, which is, for example, is rosiglitazone and pioglitazone. These are examples of that class of drugs. So we have alpha-glucosinase inhibitors like acarbose, metigron, and vibrose. The good with this drug is that they work at the villi where they prevent absorption of glucose. So we have another class of drug called creatinine mimetics. An example is exenatidine. And we have DDP4 inhibitors like stagliptin, viridiptin, and sexatriptin. So we have another class of drugs called amylin mimetics, drugs like pramlitadine. And also we have sodium glucose co-transporters like dapagliflozin and ceftriaxone and lemiflozin. Now, the sodium glucose co-transporter will look at purely in another session as the first drug in the after this general classification. Then we look this drug specifically on another specific class, on a specific class. Specifically day for this drug because it's one of the good drugs which has so many importance. It has renal protection, it has cardiovascular protections, and also it has some antihypertensive protection. So it is a triple things on this type of drugs. So let us see the summary of these drugs, how they work. Like you can see that a good example is like bigonines. They block the glucose from liver from releasing the stored glucose. That is where they block, resulting to reduced glucose circulation. And then also TZD reduces the adipose. They stop the adipose tissues from releasing free fatty acids, hence reducing the free fatty acids in the blood. Again, there is the TZD and the biguanils. They increase uptake of glucose by the muscles, where they are used for making of energy in the mitochondria of the muscles, as they reduce the glucose circulation. Also, they impair glucose uptake. Impaired glucose uptake by these ones is promoted by the biguanils. Then again, in the AGI, they reduce the absorption of glucose from what? From the intestines, and also intestinal replace inhibitors reduce the absorption of free fatty acids from the GIT, resulting to reduced circulation of glucose and fatty acids in the blood, which is toxic and causes a problem to our body. Then you can see that there is insulin secretogenesis. This one, they promote increased production of insulin by the pancreas, and this one assists in what? It assists in increasing production of insulin, and you know that insulin is the major hormone in terms of glucose utilization. When all this happens, there is reduced glucose in circulation, and also there is reduced glucose in free fatty acids in the body. So now let us look at sulfonylureas. An example of sulfonylureas is terbutamide, gravilamide, and gripazidine and gripabridine. Now, how do these drugs work? They bind to the sulfonylurea receptors and promote the release of insulin from the beta cells. That is the increased excretion of the beta cells in the pancreas. So they work at ATP sensitive potassium channel, resulting to depolarization with calcium influx, which promote insulin excretion. So they also reduce glucagon excretion and increases binding of insulin to the target tissues. That means they reduce what is called insulin resistance. So you know well that glucagon is a hormone which works antagonizes the insulin. They also may increase the number of insulin receptors. That means when you produce insulin, it has so many places where it can hang and work. So let us see the sulfonylureas pharmacokinetics. How do these molecules work? They bind the plasma protein, they get metabolized in the liver, and they get excreted in the liver or the kidney. They are orally active when you take them orally, and low volume of distribution. 90% is bound the plasma proteins. And the onset and the duration of action is that there is those which we call them short acting, like terbutamide. They work 6 to 12 hours. Then we have the intermediate acting like gripazidine and gravilamide, which takes a little bit longer. Then the longest acting is like gripabridine and gricazine, which one takes a longer time. Then the most commonly the one which is used in our setup, that is glibenclamide. It is 150 times potent than terbutamide. As it is the most commonly used as a second-line treatment after metformin in our setup. Now, what are the side effects of sulfonylureas? The side effect of this is that they tend to cause weight gain. Sulfonylureas causes weight gain due to fluid retention and edema. They also causes hyperinsulinemia and hypoglycemia. Hepatic renal insufficiency causes accumulation of these agents, promoting risk of hypoglycemia, and because they are not excreted and they circulate in the body. So you have to ensure that when you are giving patient this type of drug, you have to ensure that you check on what they are feeding. You regularly check on their sugars. So in elderly patient, it appears particular system toxicity of this agent. The elderly people, 56, the type of people you have to be very careful when you are giving this type of drugs. Then the terbutamide is associated with the high incidences of cardiovascular mortality, so you have to avoid it. You have to avoid it. So in terms of drug interaction, you'll see that sulfonylureas within the chromo and the chlorpenico and monoamine oxidase inhibitors like phenylbutazone, they increases hypoglycemic action sulfonylureas. So you have to be very careful when you are giving your patient these type of drugs because you are going to induce a further hypoglycemia. And you know that hypoglycemia is the leading cause of death in diabetes. So the other one is that drugs like clofebrate and phenylbutazone and salicylic sulfonamide, they displace sulfonylureas from plasma proteins, resulting to increased persistent hypoglycemia of this drug. Then we have the other drugs like albuterol, robenicin, phenylbutazone, and salicylic sulfonamide. They decrease urinary excretion of sulfonylureas, resulting to or the metabolism. This one also lead to increased hypoglycemia of this. So this drug, you can see that it has three pathways, three types of drugs where it causes hypoglycemia as a drug of interaction. So you have to ensure that you ask your patient, do you take any other type of drugs when you're prescribing this drug? So the other side effect is like nausea, vomiting, and abdominal pain, diarrhea. The most common one is hypoglycemia. So it can also cause hyponatremia. So that means there is a dilution of sodium resulting to water intoxication, and this one is very common in chlorpropamide. So drugs like disulfiramide, like reactions with alcohol, causing intoxication. Then this drug, again, it can cause weight gain, and so if somebody is having a sensitivity to sulfonylureas, can have a hypersensitivity reaction. Now, let us look to another class of drugs, of hypoglycemic drugs. And this time we are looking at biguanides. They are called insulin sensitizers. The two classes of oral hypoglycemics work by improving insulin target cells response, that is biguanides, and their zolinaminoids. Their aim impact is to increase the target cells response. That means they reduce what? They reduce insulin resistance. They reduce insulin resistance. And these drugs are mostly indicated in type 2 type of diabetes. So what is the mode of action of this drug? These drugs act by inhibiting liver gluconeogenesis. That means now the liver is not producing glucose, the stored glucose in it. There's no gluconeogenesis. And now, then it increases insulin sensitivity in the tissues, that is on the tissues on the muscles, which utilizes glucose and enhances insulin-mediated glucose disposal in the muscles and fats. It retards intestinal absorption of glucose, so there is a reduced absorption of glucose in the intestine. So reducing the glucose secretion in the blood. So metformin is not metabolized but excreted intact in 2 to 5 hours and perpetuate weight loss. So this result to this drug causes weight loss. Can be combined with insulin to reduce insulin requirement. This drug can be combined with insulin. So enhances insulin-mediated glucose disposal in the muscles and fats. That means they increase the uptake of the muscles to take free fatty acids and glucose. And this one reduces hyperlipidemia, low density, and very high density cholesterol, and resulting to increased high density lipids. And you remember that high density lipids is good because it is the one which acts as a transporter. So lipid lowers requires 4 to 6 weeks of treatment for that you can be able to lower lipids using these drugs. So metformin also decreases appetite, and it is the only hypoglycemics that shows to reduce cardiovascular mortality. That means metformin, it has some cardiovascular protection. So how do we give the dose? Ideally, the dose of metformin is that you should start with the lowest dose, like 500 milligrams twice per day. You increase all the way to 1 gram twice per day. If that one you don't achieve your therapeutic interest target, that means now you can go to another type of drug. So you start with 500 milligrams twice per day. You can even give 500 milligrams once per day. You can go to 500 milligrams twice per day. You can give 500 milligrams twice per day. Then you can go to 1 grams in once per day. You can go to 1 gram twice per day until you achieve your therapeutic interest. Now, what are the side effects of these drugs? This drug can cause mild diarrhea, can cause vomiting, can cause nausea. Obviously, you have to cause these, we call them GIT discomfort. Now, when forming withdraw from high risk of lactic acidosis, this disease was withdrawn because of causing lactic acidosis. It was shifting the metabolism from aerobic respiration to anaerobic respiration, which resulted to lactic acidosis, and this one used to kill the cells. So, especially in patients with diabetic. So, never prescribe Begonils in patients who have heart failure and they have diabetic. You have to choose another type of drug. So drug interactions is like cimetidine. These are H2 receptors antagonists, that is histamine 2 receptor antagonists. Furosemide, that is and diuretics and RUP diuretics, and the nifedipine, which is a calcium channel blockers in hypertension, and the other have been identified. So you have to ensure that these drugs are what are not given rate, because cimetidine will cause insulin resistance, reduce insulin sensitivity. Furosemide will also reduce insulin and also reduce insulin sensitivity, and also it is going to cause diuresis because it is antidiuretic. Then that means you are going to lose a lot of water, and diabetes itself is going to lose a lot of water, so it is going to promote more of dehydration. And that is nifedipine is a calcium channel blocker. So again, it's going to cause insulin resistance sensitivity. So this drug is contraindicated in malabsorption, for example, in GIT disturbances, like what we call irritable bowel syndrome. You have to avoid this type of drug. In low BMI, patient with less than 18 BMI, you have to be very careful. Then organic failure, like when there is a patient with a kidney failure with a creatinine clearance of more than 1.4 milligrams per deciliter, you have to be very careful. Then in liver failure, again, you have to be very careful. Active vitamin B12 deficiency, GIT intolerance, you have to be very careful when you are giving this type of drug. So let us look at other class of drug that is called the azolinadiones. This is called the TZD, like glitazones, osigglitazone, and pioglitazone. These agents are insulin sensitizers. They do not promote insulin secretion from beta cells, but insulin is necessary for them to be effective. So metabolized within a long half-life, partial mimics of insulin actions, and by binding insulin receptors or act through the proximal proliferator activator receptors. They work at the peroxisomal proliferator activator receptors. Why? Ligands of PPARY regulate adipocytes. These adipocytes are the cells which are fats, production and excretion of fatty acids, and glucose metabolism. So agent binding to peroxisomal proliferator activated receptors Y result in increased insulin sensitivity in adipose cells and liver cells, that is hepatocyte and skeletal muscles. Now you can see how these drugs works. You can see how these drugs works is that it causes what we call in the lipocytes, it increases uptake of free fatty acids, resulting to reduced free fatty acids in the blood system. It also reduces lipolysis, that is breaking down of fats, resulting to reduced free fatty acids in the system again. Then it promotes, it causes what is called a chrono expansion of beta cells, resulting to them producing a lot of insulin. And if there's high production of insulin, the insulin makes the glucose to enter the cells, resulting to reduce again glucose in the blood circulation. Again, it increases insulin actions in the muscles, and this one causes now again reduced glucose in the blood circulation because a lot of glucose is used in the tissues. In the liver, these types of drugs, they reduces free fatty acids and increases actions of insulin and reduces glucose production, resulting to reduced free fatty acids. You can see again, these drugs, they have other good advantages like reducing low density lipids, increasing high density lipids, increasing adipoectin and reducing tumor necrotic factor alpha, which is a cytokines of inflammation, and also increasing IRS, and also reducing PIR1, and also reducing CPR, which are markers of inflammation. So let us see the pharmacokinetics of these types of drugs. Both they are excreted bound to albumin, they are bound to albumin proteins. Then you know very well that something which is bound to the albumin is secreting in the body, whereas something which is bound to the fat, the lipids, is also bound to the tissues. So they undergo extensive P450 metabolism. P450 is an enzyme in the liver which causes a metabolism of drugs. There are so many isomers. Which so it's a group of enzymes, and there are so many isomers. So metabolites are excreted in the urine in the primary compounds excreted and changed in the bile. So the adverse effect is that hepatotoxicity has occurred with these agents. So you have to be very careful. You have to be doing regular liver testing of your patient before you give these type of drugs. So hepatic functions must be monitored. So drug interactions is like never give this drug when your mother is taking oral contraceptives, because she's going to conceive and they sue you because this was causes effectiveness of oral contraceptives if they are concomitantly administered. So let us look at these other like meglitinin, lepaglitinin, and the treated type of drugs. So these are excretogenous. They assist the body to produce a lot of what? A lot of insulin by the beta cells of the pancreas. And their mechanism of action is that they bind to the ATP-sensitive sodium channel like sulfonylureas, acting in a similar function, and to promote insulin secretion. However, their onset and duration of action are much shorter. When used in combination with other oral agents, they produce better control than any other monotherapy. So you have to combine them with other drugs. So pharmacokinetics is that this agent reaches effective plasma level within 10 to 30 minutes. So they are very fast if they are taken before meals. The drugs to be taken before meals. These agents are metabolized by inactive product by CYP3A4 and excreted in the bile. This is this is an isomer of P450 enzyme in the liver, which specifically works on metabolizing these drugs. So hypoglycemia is a great risk if meal is drained. So you have to be very careful if the meal is drained, so the drug should be taken before a meal. So the very rapid onset of action and short duration. This one is dipenolamine analogs, DPAL. The maximum is 1 hour, and the metabolism by liver and half time is 30 minutes. No hypoglycemia metabolites, no hypoglycemic metabolites, less hypoglycemia than sulfonylureas. It has less hypoglycemia than and sulfonylureas. So improves postprandial glycemia. That is, postprandial is after taking meal. So it improves. So this patient who, when you do the postprandial, that is you test the glucose of the meal. This one is reduced because you see it works very fast. Now it is less effective in decreasing fasting blood sugar levels and HB1C. So it is less effective. So it is good for postprandial. The glucose which is produced after you take meal is the best for this. So the disadvantage of this drug is that it fails to provide a stable 24-hour blood glucose control. And it has a very complicated dosage style where you can at least even give somebody 8 tablets. That is overdose. That is a pill burden. It can resort to pill burden. Now, other side effect is like headache, dyspepsia, arthralgia, and weight gain. And weight gain, lipoglitazone avoided in liver diseases. You have to avoid this drug in liver diseases. So the drug interaction is that this drug inhibit CYP3A4. These drugs inhibit like ketoconazole, fluconazole, erythromycin, etc. So you have to be very careful when you're giving these drugs in this class with these type of drugs because they inhibit its function. So the drug that promote CYP3A4, like imavetrate, carbamazepine, and rifampicin, decreases the effective of this drug. So decreases the effectiveness of this drug. So you can see the drugs which promote the what? These drugs are the drugs. So you have to be very careful. You have to counsel your patient, ask previous medical history, ask whether the patient is taking other drugs so that you don't cause this confusion. So the combination of gemcitabine and ribapentine has been reported to cause severe hypoglycemia. So you have to be very careful when you're combining this type of drug. So let us see the class 2 type of drug. Let us look, they are called incretin mimetics. Now, incretin mimetics are naturally occurring hormones that are released from the GIT throughout the day, and the level of active incretins increases significantly when food is ingested. So this one now is promoted by activation of taking food. This incretins increases. So endogenous incretins, that is glucose-like peptide 1 and glucose-dependent insulinotropic peptide, facilitate the response of the pancreas and liver to glucose fluctuations throughout their actions on pancreatic beta cells and alpha cells. So the combination of increased insulin production and decreased glucagon excretion reduces hepatic and glucose production when plasma glucose is elevated. So the physiological activity of incretins is limited by the enzyme dipeptidase 4, DPPT4, which is a rapid degraded active ingredient after their release. So the ingredient effect is diminished in type 2 diabetes. The levels of GLP-1 are decreased, and the insulin tropic response to GIP is diminished but not absent. So defective GLP-1 releases and diminished response to GIP may be in important factors in glycemic dysregulations in type 2 and diabetes. So exenatendin is another type of example of this incretin mimetics. Exenatendin is a long-acting analog, and it is resistant to DDP4 degradation and obtained from the saliva gland of venom of Gila monster. That is where it is harvested. So potent agonist at GLP-1 receptors, that is incretin mimetics. It is orally inactive and given subcutaneously. It is because if you give it orally, it's a protein. That means it is going to be digested, and it is given subcutaneously 5 to 10 micrograms twice per day. So GLP-1 receptors agonists stimulate insulin secretion from beta cells of pancreas, and that one they are excretory, and it decreases glucose release. Glucagon is the hormone which act against insulin, so they decreases glucagon release. So slows gastric emptying, and this one slows rate of nutrient absorption, resulting to slows nutrient retention. So decreases appetite by acting at the level of hypothalamus. That is, it reduces weight. So at the level of hypothalamus, it causes low appetite. It is used along with metformin or sulfonylureas in type 2 diabetes. So long-acting synthetic GLP-1 analog, long half-life, diabetes type 2 for once daily injectable therapy, and you give 0.6 milligrams dose and you titrate the dose. So adverse side effect is like headache, diarrhea, antibody formation of pancreatitis, and this is liraglutidine type of incretin mimetics. So let us look at things like alpha-glucosinase. Alpha-glucosinase like cyclase, maltase, glycoamylase, and dextrinase. These are enzymes. These are enzymes in the class of what? Alpha glucosinase. Example is secrase, maltase, gluconase, and dextrinase. These types of enzymes, we call them hydrolysis types of oligosaccharides. They work on monosaccharides and polysaccharides, which are these absorbed. The acarbose also inhibit pancreatic amylase. Pancreatic amylase is the enzyme which deals with the starch from the liver. So the normal postprandial glucose lessens in blunted glucose level less mostly and remain selective and limited from a prolonged period of rest of insulin response in required and hypoglycemic is avoided. So you can see that these drugs works basically on the villi, the absorption, where they do what? Alpha amylase, it stops starch from being absorbed in the air, and then maltase isomates and gluconase stops glucose from being absorbed. And also the site of contentedness, and you can see also sucrase stops absorption of glucose from the GIT. So these drugs basically works by preventing absorption of these oligosaccharides and monosaccharides. So acarbose and the vogravose and the megaton mechanism of actions is that these agents are taken at the beginning of a meal, drained carbohydrate digestion by quantitatively inhibiting alpha-glucosinase, a membrane-bound enzyme of the intestinal blast border. Hence, there is no absorption of this digested food. So there is this type of drugs lowers HbA1c level and lowers body weight, because there is no absorption, and lower serum triglycerides, and megaton can block isomates and alpha and beta glucosinase. These are glucose enzymes which breaks out the beta glucose. So alpha glucosinase inhibitors, their pharmacokinetics is that acarbose is poorly absorbed, and the megaton is absorbed and excreted by the kidney. Both agents are exert their effect in the intestinal lumen where they prevent absorption. So the adverse effect is that these drugs causes flatulence, diarrhea, cramping, and can cause hypoglycemia when used with sulfonylureas. When used in sulfonylureas, they can cause hypoglycemia. So metformin bioavailability is very decreased when used concomitantly with these alpha glucosinase inhibitors. So you have to be very careful because you can induce hypoglycemia. These agents will not be used in diabetic intestinal pathology. Patients who have intestinal pathology like irritable bowel syndrome, diverticulous, you have to be very careful. Volvulus, intestinal obstructions, these drugs, you have to be very careful. People who have been done bypass surgery, again, you have to be very careful when using this type of drugs. So, irritable bowel syndrome and intestinal obstructions, all those type of conditions, you have to be very careful when you're giving these drugs. So let us see another class of drug, which is very interesting. But this class of drug, we will see it again somewhere in a special way as a specific, we will study it seriously as a special type of drugs. This one is called peptidase inhibitors, or DDP4 inhibitors. An example is stagliptin, pigidroptin, and the orally active selective inhibitors of DDP4 enzyme that inactivate GLP-1, result in increase of GLP-1 activity and prolonged action. So anti-daily dosing is very effective, and the mode of action is that increases insulin excretion. So they are scriptinious, and it decreases glucagon release and it drains gastric emptying and suppresses the appetite. So they can be used along with the metformin and sulfonylureas. Adverse effect is like nasopharyngitis, which is concentration of substance P can increase this one. They can also cause gastric distress and diarrhea. Stagliptin therapy requires adequate level of GLP-1, which may not be feasible in the patient with a carbohydrate-free diet. Amarin is another type of drug which is a mimetics, and this one is a endocrine hormone peptide hormone co-secreted with insulin from pancreas beta cells. It inhibits glucagon excretion, reduces gastric emptying, and suppresses appetite. An example is pramlintide is a modified amarine peptide which is agonist at amarine receptors, GPSCL. It is used for 15 to 60 micrograms subcutaneously because it is given subcutaneously because it's a protein. So if it's a protein, it can be digested when you take it in the GIT. So before meals, adjust to insulin diabetes type 1. Adverse effect is like nausea, diarrhea, and headache. Let us look another type of drug which is called sodium glucose cotransporter type of inhibitors. These drugs works on the proximal tuberous of the kidney. They have renal protective, they have cardiovascular protective. So their major function is that they prevent the absorption of the glucose back to the kidneys where they work at the proximal. Specifically, they prevent 90% of the absorption of the glucose in the body. So it is excreted, resulting to no glucose secretion. The problem is that these drugs does not promote uptake of glucose into the mitochondria, so a patient can come with dizziness if it is given alone. Also, this drug, it has cardiovascular protection. It has cardiovascular protection and also endothelial inflammation. That is, in this capacity of inflammation and coagulation, it has protection. But this type of classes of drugs, you will see them later on as a specific type of drugs because they have very interesting capability of protecting patient. So in summary, examples of this type of drugs of sodium glucose cotransporter inhibitors is dapagliflozin, sulfagliflozin, and lemogliflozin. They inhibit sodium glucose transport decrease in the proximal tuberous. You remember that in the proximal tuberous, the first part of the proximal tuberous is where the 90% of the glucose is reabsorbed. Then the second one is where the 10% is reabsorbed. They are concerned with preventing the 90% glucose reabsorption, where it is excreted in the body. So it is this drug is extremely distributed on the proximal tuberous of the kidney, and they can cause weight loss, and there is no hypoglycemia as they excrete only the excess glucose from the body. They excess the 90% glucose from the body. So this one they improve insulin resistance. So there is insulin resistance. They are beneficial because they have a protection with the diabetes. They are very beneficial. They have a cardiorenal protection. They have a cardiorenal protection. And disadvantages is that they can cause polyuria because a lot of water will be required to clear the glucose in the tuberous, and they can cause polydipsia. Increases risk of renal infection because of the glycosuria, and the risk of sodium loss as sodium glucose transporter has been inhibited. So they can risk it to cause what you call electrolyte imbalance. So let us see another drugs like what you call them, they works on the bile. They are called bile acid secretants. An example is choleseveran hydrochloride. This one is a secretant and cholesterol-lowering drug, and they are used in treatment of type 2 diabetes. Enterohepatic secretion, that is where the blood enters from the intestines to the liver, because it has all the food which are absorbed of the GID from the liver, they have to pass through the liver. So they need to be increased in fascinogen receptors, resulted to nuclear receptors with multiple effect on the cholesterol, glucose, and bile acid metabolism. This one lowers HbA1c levels, and the side effect is GID complications like constipation, flatulence, and drug interactions is like the impairs glycogen and fat soluble vitamins. So never give in a deck. So drug of choice in comorbidities. Sometimes diabetic patients, they have comorbidity like hypertension, they have overweight, they have renal diseases, they have hypertension, they have heart failure. So this is the summary of the type of consideration. For example, if a patient is having high BMI, you can give metformin and gliptins, and in the presence of GIT symptoms, you give sulfonylureas and gliptins and glitazones, and in renal dysfunction, you give gliptins, glitazones, plus or sulfonylureas. In aging patients, you give meglitazine and gliptins, but you have to be very careful because aging people, they have a poor in feeding. In hepatic dysfunction, you have nitaglitazine and saxagliptin, and you have to be very careful. And if the patient, you want them to have a compliance, you give gliptins and glitazones. And because you are living in sub-Saharan Africa, where you are living in less than $1, the cost is a very important factor in terms of public consideration of how many people are going to afford these drugs in the approach of primary health care and universal health care and universal health coverage. So the cheap drugs like metformin, sulfonylureas, glitazones are the best in our setup. So what is the present mode of treatment of diabetic patient? How do you approach this? First of all, you have to modify the lifestyle of the patient, like you advised on the diet to reduce the amount of fat they are taking, reduce the amount of salt they are taking. They modify, they increase the amount of, reduce the amount of carbohydrate. They take complex sugars instead of sugars. They as well as the weight control by doing exercises. And they do exercise regularly. They control their weight to 10 to 18 to 24 BMI. And if these lifestyle modalities does not work, you can start with metformin from 500 milligrams. Then you adjust the maximum dose of 1 gram 3 times per day. If that one does not work, you can go to sulfonylureas like glibenclamide, and then glibenclamide you give 5 milligrams, then you increase to the maximum dose. If that one does not work, you can either add acarbose, or you can add DD4 inhibitors, or you can add glitazone, or you can also add insulin, or you can add any of these with plus insulin, so that you can achieve your therapeutic interest. Now, the point is that the more you start your patient on insulin in time, the longer the rep span. So it is better if you are able to start a patient on insulin in early, it will prevent all these types of complications. But to remember that insulin has a lot of stories in terms of injections, stigma in the community, cost, all those type of things. But later on, we'll talk about insulin as a way of managing type 2 diabetes, and also as a way of managing type 1 diabetes. We will see the reason at what point do you put insulin. Okay, thank you very much for listening for this lecture. Have a pleasant evening. We'll meet any other time for a further discussion. Thank you very much.